Good morning. Welcome back to Open Med School. I am Dr. Andrews, Professor of Medicine and Consultant Neurologist. Today we will be discussing Internal Medicine Competency 1.6 Compensatory Mechanisms in Heart Failure. So, heart failure is a clinical syndrome. It's a complex syndrome which is characterized by inability of the heart to pump sufficient blood to meet the demands of the body. It can be due to a structural cause or a functional cause, and basically there are two mechanisms. One is the defective contraction or systolic failure, second is a defective relaxation or the diastolic failure. When heart fails, the body activates several compensatory mechanisms which initially support the heart and the cardiac output but eventually contribute to disease progression. So let us see what are the major compensatory mechanisms. The major compensatory mechanisms, the first and foremost is the activation of the sympathetic nervous system. When the heart fails, the SNS gets activated. That is why you get tachycardia. It in order to it increases the contractility, it increases the blood pressure. Second important thing is the RAS activation, renin-angiotensin aldosterone. Then there is a remodeling of the ventricular myocardium. There is secretion of ADH, and finally the ANP and BNP. So this is how these are the compensatory mechanisms. So what's the problem with the compensatory mechanisms? The compensatory mechanisms initially help, but on long term this will lead on to damage. So first we look at the Frank-Starling mechanism. The Frank-Starling, the heart increases stroke volume in response to increased preload. That is when the end diastolic volume increases, the ventricle dilates. Volume increases, so there is a increase in the contractility depends upon the initial length, and so initially the Frank-Starling slow is beneficial, but chronic overstretching leads on to contractile dysfunction. So this is the curve showing the curve 1, and when the stretching is more, the stroke volume gets increased. So that is the concept. So in early heart failure, increased venous return enhances ventricular filling. As per the Starling's law, this augments cardiac output. However, persistent volume overload leads on to dilation and loss of contractility, which is as per reference given in Davidson. Now we go to the second problem. So first is we have considered the Starling's law. Second is the myocardial hypertrophy and cardiac remodeling. There are two such types of hypertrophy. One is called the concentric hypertrophy and second is the eccentric hypertrophy. Concentric hypertrophy occurs in response to pressure overload, as in hypertension, aortic stenosis. Eccentric hypertrophy occurs when there is a volume overload, as example in aortic regurgitation and mitral regurgitation. So this is the normal heart. Here you can see the concentric remodeling. In concentric, what is happening? The thickness occurs at the expense of the cavity. So there is not much cardiac dilation. That is why in aortic stenosis and systemic hypertension, even though the ventricles are thickened, there is not much cardiomegaly. In eccentric hypertrophy, what is happening? There is the eccentric hypertrophy. The dilation is occurring. So the ventricle expands. So this is the eccentric hypertrophy. This is the concentric hypertrophy. As mentioned, eccentric hypertrophy occurs in volume overload situations like MR and AR. And concentric hypertrophy occurs in conditions like aortic stenosis and systemic hypertension where there is a pressure overload. So what is myocardial hypertrophy and cardiac remodeling? Cardiac remodeling refers to molecular, cellular and interstitial changes. So there is a molecular changes, there are cellular changes, interstitial changes that manifest clinically as change in the size, shape and function of the heart. Please remember these terms: the size, shape and function of the heart after an injury. Initially it is an adaptive thing, but these changes become maladaptive. Reference Brown walls. Now we have mentioned that there is the shape is become abnormal, the size becomes abnormal, and also the function becomes abnormal in remodeling. So one change is the myocyte hypertrophy. Second is there is a fibrosis can occur, chamber dilation, and finally there can be altered gene expression. So as per Harrison, persistent stress from volume or pressure overload leads to cardiac remodeling characterized by myocyte apoptosis, hypertrophy, and extracellular matrix changes. That's why it is mentioned shape, size, and function of the heart becomes abnormal. The third is the neurohormonal adaptations. Sympathetic activation is an early response to reduce cardiac output but leads to increase in afterload and oxygen consumption. So sympathetic nervous system supports the heart, one of the important support, but it leads on to increased oxygen demand and oxygen consumption. So it leads on to further dysfunction. So what are the neurohormonal adaptations? These are critical in the pathophysiology of progression of heart failure. So sympathetic nervous system activation leads to increased norepinephrine, the heart rate contractility increases, there is vasoconstriction, maintain the blood pressure, but the long term it produces increased myocardial oxygen demand, beta receptor downregulation, development of arrhythmias. So sympathetic nerve, that is why in heart failure one of the treatment modalities you give beta blocker. So here it shows when there is a heart failure, the heart rate increases, the vasoconstriction occurs. But again remember, this will activate the renin-angiotensin system also. That will help to maintain the BP initially. So SNS or sympathetic nervous system and renin-angiotensin system works together. Next is a RAS activation or renin-angiotensin is very important. Decrease renal perfusion. When there is a cardiac failure, there is a decreased renal perfusion which leads on to renin secretion, increased angiotensin, vasoconstriction, and aldosterone release. Aldosterone will produce sodium water retention, increase the preload. Initially it is helpful, later long day it produces fibrosis and vascular remodeling. So RAS blocker is one of the cornerstones in management of heart failure. So here you can see that the angiotensinogen is produced from the liver. Renin is the enzyme that acts on angiotensinogen, converts to angiotensin 1. That is acted upon by the ACE, which is secreted from the lungs. Angiotensin 2 is produced. Angiotensin 2 is the most potent vasoconstrictor. So this will produce vasoconstriction, tries to raise the blood pressure. It also acts on the adrenal gland, produces aldosterone, which produces reabsorption of sodium chloride and water. Again, initial phase it is helpful. So remember this RAS activation is very important. So RAS activation contributes to volume retention, vasoconstriction, but it produces myocardial fibrosis, playing a central role in heart failure progression. So remember, RAS blockade is very important in heart failure. Next comes the antidiuretic hormone or vasopressin. It is released due to decreased arterial stretch. It promotes water retention and hyponatremia. So hyponatremia is very common. So from the pituitary, ADH is released when there is decreased arterial stretch. The receptors are sending signals from the pituitary, ADH is secreted. ADH will produce from the kidney, it will increase water retention. So remember, ADH secretion promotes water retention, at the same time it produces hyponatremia. So syndrome of inappropriate ADH secretion is common in heart failure. Then finally comes the natriuretic peptides, the atrial natriuretic peptide and brain natriuretic peptide. They are counter-regulatory. They are released from the atria and ventricles when response to stress. When there is a volume overload is there, the atria and ventricular muscles are stressed and this leads on to release. It promotes natriuresis, vasodilation, and inhibits the RAS and sympathetic nervous system. So it is a natriuretic peptides are beneficial, or it is counteractive to this compensatory mechanism when it is overacting. So here the pre-pro natriuretic peptide is produced, then becomes pro-NP in the cardiomyocyte. Then there is an enzyme neprilysin. So then it act as the A and B and B and B, it act on the cells. It is GTP via, it is converted to cyclic GMP and acts. So in the cardiac failure, we use neprilysin inhibitor, so that there will be more amount of ANB or BNB, and that is helpful in managing heart failure. So the importance of BNB is useful diagnostically and prognostically in heart failure. So it is useful for the diagnosis and prognosis. Brain natriuretic peptide levels correlate with ventricular filling pressures and are useful in distinguishing cardiac from pulmonary cause of dyspnea. When a patient comes with, especially a COPD patient, their patient can develop a heart failure. So in such cases, the estimation of proBNP is very beneficial or very useful in identifying whether it is a cardiac cause or respiratory cause of. So the maladaptive consequences of compensatory mechanisms we have discussed. So the one is the SNS, the sympathetic activation producing tachycardia, arrhythmia, and myocardial toxicity. RAS activation produce volume overload and it produce fibrosis. Ventricular remodeling again produce fibrosis and dysfunction of the heart, and ADH secretion maintains volume but it produces hyponatremia. And the atrial natriuretic and the brain natriuretic peptides are counteractive and is beneficial. So the implications for the management of heart disease, for heart failure, we have already said the beta blockers block the sympathetic nervous system, AC inhibitors block the RAS, the mineralocorticoid receptor blockade, it blocks the aldosterone, the diuretics reduce the preload or fluid overload, and the RNA, the sacubitril valsartan, enhances natriuretic peptide activity. We have already told that the sacubitril is a neprilysin inhibitor. Neprilysin is a enzyme that degrades the natriuretic peptides. So this is the clinical implication for this. So these are the references, and today I have discussed about the compensatory mechanisms and the basis of pharmacotherapy of heart failure. Hope it was useful to you. Thank you.